in. Good morning to everybody. This is a quiz session which is to familiarize you with some of the ECGs which I'm sure many of you have seen. The idea is to show you those ECGs, make you think, give you a diagnosis after that, and then discuss related issues. That's what we are going to do now. Look at this ECG. I want you to enter the findings and the diagnosis. You have 30 seconds. There's nothing great. All of you would have seen this. No takers? Here we go. What this ECG shows, basically there is sinus tachycardia. There is right atrial enlargement. If you see the P wave in lead 2, you can find that it is tall and peaked. There is of course a right axis deviation and a right ventricular hypertrophy. This could be seen in any condition where there is a cause for right ventricular hypertrophy like pulmonary stenosis or pulmonary hypertension. Remember, right atrial enlargement you would diagnose if the height of the P wave is more than 3 millimeters. It is best seen in lead 2, and the usual causes are related to the pulmonary system, either pulmonary stenosis or pulmonary arterial hypertension. Hence the term P pulmonale to denote RA enlargement. You could also see it in tricuspid atresia, in Epstein's anomaly, and some people refer to the huge P waves that you see in Epstein's anomaly as Himalayan P waves. Okay. Having spoken of right atrial enlargement, let us also recollect what is left atrial enlargement criteria. If the width of the P wave is more than 3 millimeter, that is left atrial enlargement. And the P wave is usually bifid, the proximal portion being created by the right atrium and the distal portion by the left atrium. And the terminal negativity of P wave in V1, if it's more than one division in depth and one division in duration, that also would be an evidence of left atrial enlargement. This is a very sensitive criterion for left atrial enlargement, but somewhat less specific. For instance, if there is a large RA as in Epstein's anomaly, you may spuriously get this sign. So causes for left atrial enlargement would be mitral valve disease, left to right shunt, and if it is biatrial enlargement, if you have a P wave amplitude more than 3 millimeter and width more than 3 millimeter, you call it biatrial enlargement. You could get in mitral valve disease with severe PAH, in Luton-Basher syndrome, or in constrictive pericarditis. So these conditions could be biatrial enlargement. So there is some digression to theory because none of you answered the question. We will go back to showing you ECGs. Look at this. Do give me a response. We have moved away from atrial enlargement. No responses? Vikas, tell me what it is. Can everybody hear me? Okay. So obviously some people are hearing. He noted that the P wave is inverted, and Deva Prasad thought that there was LVH. Ikal, you need to see where is the P wave inverted. It's not enough to say that P wave is inverted. This actually showed situs inversus dextrocardia. Why did we say that? The P wave was inverted in lead 1. You can see that the P wave is inverted in lead 1, which Ikel correctly noted, but it is upright in AVR. That also you should note. And see that the QRS voltage is progressively decreasing from V1 to V6. And actually there is good voltage in V4R and V5R. So there is no LVH. What you found is situs inversus and dextrocardia. Yes, Dr. Vesas, you're asking me something? Because I think it may be better if you chat. Because otherwise there is a disturbance and I can't hear you. Do type in your question. While you are doing that, look at this. When you have an abnormal P wave morphology, it may reflect a retrograde activation of the atria. As in junctional rhythm, you find that the P wave is inverted in leads 2, 3, and AVF. And to determine the atrial situs, you must see that what the orientation of the P waves are in lead 1 and AVR. If it is upright in lead 1, inverted in AVR, the atrial situs is solitus. If the P wave is inverted in lead 1, upright in AVR, it denotes situs inversus. You can have a more complicated situation in visceral heterotaxy syndromes when there are bilateral SA nodes with fluctuating pacemaker function, in which case you can get a situs solitus like pattern in one ECG and a situs inversus like pattern sometime later. And a junctional rhythm in patients with that is the feature in right isomerism, and in left isomerism you can get a junctional rhythm or complete heart block. But for situs solitus versus inversus, look at lead 1 and AVR, and for dextrocardia, look at the QRS progression from V1 to V6. Any question? Okay, here we go. What do you see now? You should try to respond quicker, because only then I'll be able to show you more number of ECGs. Can you take yours? Okay, you're not responding, so all that it showed was LTH with volume overload. Why didn't any of you point it out? Look at that R wave in V5 V6 and the DQ in V5 V6 and the height of the R wave in V5 V6. We're going to come back and tell you in detail about diagnosing LVH and RVH. But for the time being, note that this is sinus rhythm, normal QRS axis, left ventricular hypertrophy because the voltage criteria are satisfied, and the Q waves in V5 V6 tell us that it's LV volume overload. Okay? Do respond, otherwise this session will have less meaning. Now see this one. What does this show? Give me a response quickly. Do you hear me? You need to know that there is left ventricular hypertrophy. And why the query initially? It's pretty evident. If you see the V5, V6, they are quite tall, and you can see the grid. So there's no difficulty in saying that the R waves in V5, V6 are more than 25 millimeter, and there is an ST depression, but T inversion. So that suggests a pressure overload or strain pattern. In the previous ECG, you had seen LVH with volume overload, and now you are seeing LVH with pressure overload. Okay? So that is LVH with pressure overload. You would think of conditions like coarctation or severe aortic stenosis when you see this. So at this point, let's just look back at the criteria for LVH. You know what the voltage criteria are. The R wave height in V5 or V6 exceeding 25 millimeter. The R wave height in AVL exceeding 13 or 15 millimeter. The R in V5, V6 plus S in V1, V2 exceeding 35 millimeter. These are some of the voltage criteria for left ventricular hypertrophy. Along with that, if you find a deep Q wave in the left sided leads, you say that there is a volume overload. And if you find an ST depression and T inversion, you say that there is a pressure overload. And the volume overload occurs in shunt lesions like VSD, ductus, or an AV canal defect. While conditions like VSD, ductus, MR, AR, everything is volume overload. While just as we said a little while before, coarctation, hypertension, or aortic stenosis causes pressure overload. You must also know what's the Katz-Waxtel phenomenon, which I'll show you as we go along, which means there is a biventricular hypertrophy. Now see this. It's a little less distinct compared to my previous ECGs, but I hope you can see this and give me a diagnosis. Yep, I'm waiting for a response. You're all very slow in responding today. Deva Prasad has noted that it is normal sinus rhythm, axis is right, very good, and there is RVH with strain, very good. So it showed normal sinus rhythm, right axis deviation, RVH. Here, remember it is an RSR in V1, and when there is an RSR in V1, you look at the height of the second R. If that is more than 15 millimeter, that is when you diagnose right ventricular hypertrophy. Here it is very obviously much more than that, so diagnosing right ventricular hypertrophy is easier. But this is to remind you that instead of getting a tall monophasic R, which I will show you also, you may get an RSR, and if the second R is taller than 15, you could diagnose right ventricular hypertrophy. So you diagnose RVH based on the RV voltages in V1 when the R by S ratio is more than 1, or an absolutely monophasic R in V1. If you find RS complexes in mid-precordial leads with a delayed transition, and if you find an initial slurring in the QRS or a QR pattern in V1, a significant prolongation of the ventricular activation time, that is the onset of the QRS complex to the peak of the QRS complex, associated right atrial enlargement, or an upright T in V1 after 3 days of age and up to prepubertal age. Remember, the T waves are inverted in the first 3 days, but after that, if you find that a T wave is upright in an infant or in an young child, it is abnormal. You expect it to be inverted, and this relevance is lost after puberty. So these are the criteria for right ventricular hypertrophy. If it is RV volume overload, you wouldn't see any of these. What you see is an incomplete or perhaps complete right bundle branch block. Example would be an atrial septal defect or an AV canal defect. And just as we showed in our representative ECG, to diagnose RVH in presence of RVBB, the second R should be 15 millimeters. Any questions? And biventricular hypertrophy, large equiphasic complexes in mid-precordial leads, the combined voltage of which exceeds 45 millimeter, that's Katz-Bachtel phenomenon. Or if you find LVH but the axis is right, or you find LVH but there is a clockwise rotation in the test leads, you find LVH but there is a tall R in V1 also, or an R by S ratio greater than 1. So these are the ways in which you can diagnose biventricular hypertrophy. Some of the causes for biventricular hypertrophy: a large VSD or a large AP window where there is both LVH and RVH. We move to the next one. See what is this? Simple enough, so I won't give you too much time on this. RVH with strain, very good. That's all that it shows. But you should have also noticed that there is a left axis deviation. So in this ECG, you do find RVH and strain, but the axis is left. That's a pointer that you may be dealing with an AV septal defect with pulmonary arterial hypertension. Supposing this belongs to a Down syndrome child and this ECG was seen, it would be very characteristic of an AV canal defect with PAH. Now look at this. What does this show? I'd be happy if I get more responses. Yes, it shows RVH with strain. Good. Now people are getting the point. You do have a right axis deviation. Very good. Satish, you are right. There is a right atrial enlargement. Look at the the P in lead 2, and you do find RVH with strain. So this is quite compatible with say valva PS or severe PAH. Somewhere you should also note, look at this P in V1. This might denote an associated left atrial enlargement, but if there is a large right atrium, as I said, there is a huge right atrial enlargement, the negativity in P1 may be related to that alone. So interpreting it as a left atrial enlargement may not be specific. Good. So that showed normal sinus rhythm, right atrial enlargement, right axis deviation, RVH with strain, and that could go with severe PS or severe pulmonary arterial hypertension. Let's see this now. So this showed normal sinus rhythm, right axis deviation, RVH, and a sudden transition from V1 to V2. Look at this. This is V1, this is V2. So this sudden transition along with right axis deviation is a pointer that you are dealing with pathology. Oh good, Dev Prasad said right away that it is pathology, very good. So you're seeing variations of the themes of right ventricular hypertrophy, left ventricular hypertrophy. How do you diagnose the hypertrophy itself? What will help you to draw a conclusion regarding the basic etiology? All these things in these few examples we have tried to show. See this now. Same thing. It's just that the transition is less dramatic. In the previous one, it was such an impressive transition that you straight away came with the diagnosis of TOF. In this, that V1 to V2, what should impress you is that it is a monophasic R in V1, while V2 it has suddenly become a small R, not very small, but the S is the more prominent one, and the axis is right. So this would again be pathology. I showed these two variations because this is something that you're going to see very commonly. Any questions? Okay. Now we are moving to a different theme. What's the diagnosis in this ECG? Good, Vinu. It is QT prolongation. You can see that the QT practically occupies the whole of the RR interval. As the rule of the thumb, you would look at the QT interval as in relation to the RR interval, and if it is more than half the RR interval, the QT is likely to be prolonged. But here, the QT is practically the whole of RR interval, and that is prolonged QT. And you say that QT interval is prolonged when it is more than 440 in males and 460 milliseconds in females. It could be due to congenital long QT syndromes. In pediatric context, it's more often congenital than others, but it could be drug induced. Look at some of these patterns of QT interval prolongation. The first, on the top of the trace, it shows normal QT interval, and you can have a very indistinct termination of the T wave with a TU complex, or you could have a sinusoidal, slowly generated T wave, or you could have a T wave inscribed after a very long ST segment. These are all variations of ST and T which can occur in long QT syndromes. And in this, see the normal QT interval above, you could have a very broad-based wide T wave, or you can have a broad-based double hump T wave, or you could have a low amplitude deflection on the descending limb of the T wave. These are various T wave morphologies that could occur with long QT syndrome. And I want you to remember this. You deal with 3 common long QT syndromes. The number of long QT syndromes is ever on the rise. I think on the last count it was 10. If somebody tells me it is 12, I wouldn't be surprised. But the first 3 are the commonest. You must have an idea as to what is the defective gene. In the first 2, it is in the potassium channel. Third is in sodium channel. What is the thing that provokes syncope? Syncope occurs when long QT syndrome is a tossed. In long QT1, it is emotional stress or swimming. In long QT2, it's a sudden loud noise. 3 does not have this. Syncope could occur during sleep or during rest. So remember this. And the typical resting ECG in long QT1 has a broad T wave. In 2, there is a low amplitude T wave with notching. And 3, there is a long isoelectric segment. And the response to beta blockers is best in the first, less so in the second, and none or uncertain in long QT3. So this slide I would like you to carry in your head. This is something totally different. Have a look at this. Something simple. I want you to give me the diagnosis. Come on. It's a very common entity. That's disappointing. All that is showed was a sinus rhythm with right axis deviation and incomplete right bundle branch block. And what would be the diagnosis? Yes, good Satish. Tell me the diagnosis also. Did you mean pulmonary embolism, Vinu? No. These are after all pediatric ECGs. Won't you think of an atrial septal defect, ostium secundum? This can be considered fairly. Yes. Move on to the next ECG. Do shut up. It was AST. Let's look at this ECG now. Describe the findings and give me the diagnosis. It shows normal sinus rhythm. Axis is to the right. There is right atrial enlargement. Yes, very good. We know it is Epstein. What you found is normal sinus rhythm, right axis deviation, very tall P waves, the extreme right axis deviation, the PR interval is prolonged, and this is characteristic of Epstein's anomaly. I would like you to look at this QRS carefully. I would rather call this polyphasic QRS complexes. So if there is an RS, so there are too many deflections. So call it polyphasic QRS complex or splendid QRS complex. Very good, Shada. So this is Epstein. Okay. And in Epstein, remember, the QRS typically exhibits a right ventricular conduction delay, which manifests as polyphasic QRS complexes. First degree AV block is frequent. You may get a WPW pattern. In the absence of pre-excitation, the QRS is not. Right atrial enlargement is present in most patients, and some have the Himalayan P waves. Now let's see this. Let me have a diagnosis for this. I'm sure that you will come with a diagnosis in this. Come on. It's a big jump from Epstein, something totally different. Venu thinks that it is a sinus rhythm, normal axis, and LVH, and therefore she would think of corrected transposition. The one thing that you should not think is corrected transposition, Venu. Look at the septal Q waves. V5, V6 are good Q waves. Shocking. This is a child. See the AVL. You have a very deep Q wave, and look at V5, V6. You have a very deep Q wave. What would slightly mislead you is the height of the R wave in V5, V6. But remember, Al kappa often has significant mitral regurgitation and it's a dilated ventricle. So therefore, finding a prominent R in V5, V6 is not at all uncommon. You should definitely not think of corrected transposition when you're seeing a good Q wave in V5, V6. Okay, any question there? So let's move to something else. Good, Satish. It is WPW, but can you go further from there? At least more people are spotting the WPW. Where is the accessory pathway? Is it in the right ventricle or in the left ventricle? At least that much you can say. You may not be familiar with that concept. So this is right ventricular pre-excitation for sure, because it's a negative delta in V1. And if you would like to know how we would localize the accessory pathway, look at the V1 delta wave. If the V1 delta wave is negative, it's an RV pre-excitation. If it is positive and the QRS is positive, it is an LV pre-excitation. And now you are trying to see where in the right ventricle it is or where in the left ventricle it is. In the right ventricle, if you find everything negative, you find QRS is negative in 2,3 AVF and the delta is negative, it is a postroceptal. If you have a clear left axis, which means lead 1 and AVL are standing out, 2,3 AVF are not, that is a right free wall. And if you have an inferior axis, which actually would mean that lead 1 and AVL are negative, then it is antroceptal. So the right-sided pathways can thus be separated as postroceptal, antroceptal, or right free wall. And the left-sided pathways, you try to see whether it is postroceptal or lateral. And if you have a negative delta, in other words, it's a left side that the left ventricular pre-excitation, but everything is negative, it is postroceptal. The same principle as on the right side. And if you find isoelectric or negative delta in lead 1, AVL, and V5, V6, it's a lateral pathway. Try to remember this slide. Now, something else. Let's say that this is a 2-year-old child. The child is cyanosed. Quick. Yes, PR is prolonged, but you saw only the PR prolonged, Deva Prasad? You're trying this, now you're spotting more and more things. I'll have to put together all the answers and reach the correct one. Can anybody give me a diagnosis on this? If I tell you that this is a 2-year-old child with cyanosis, just the left hand R in V1. Good, because it is tricuspid atresia. The striking things are the left axis deviation and the absence of the RV forces in V1. Good, because now look at this. This child had a surgery 3 months ago. Give me the findings and what could have been the surgery. Tell me the findings first. No? So what the, very good, Vinu. People are coming with their responses now. It does show sinus rhythm, right axis deviation, and complete right bundle branch block. So that is very characteristic of a tetralogy which has had an ICR, and you would look at that QRS duration critically for its prognostic value. Okay. The recording is paused. The recording got paused. Resume here. It's complete heart block. Very good. Would you like to say anything more? Let me say that this is a 5-year-old child complete heart block. Is this likely to be congenital or acquired? Congenital because it's a narrow QRS complete heart block. Complete heart block is evident. Look at this rhythm strip. You find this P wave. This P wave has no relationship to the QRS that follows. So it's clearly a complete heart block. A narrow QRS complete heart block is a feature of, yeah, good. Vinu said that. It's a feature of congenital complete heart block. Good. Now look at this ECG. If you can read, it's a 2-year-old child with complete heart block. Can you comment anything more on this ECG? I told you it's complete heart block. I thought that would be pretty obvious. CTGA, very good, Vikas. And why did you say it is CTGA? Because look at V1, you find an initial Q, and look at V6, you don't find the septal Q. Clearly, there is no Q wave there. So the Q in V1 and the absent Q in V6 tells you that it is CTGA. And after all, CTGA is one of the common causes for complete heart block in children. So remember, in CTGA, absence of the septal Q wave in the left precordial leads is characteristic. Presence of Q in right precordial leads, if it is there, well and good, but it is not a very sensitive sign. Left axis deviation is common, and varying degrees of AV block could be seen. It may not always be complete heart block. In another patient, it may be a first degree block only. Moving to a different field. Give me the diagnosis here. It's a narrow QRS tachycardia. You could go further than that. We thought it is AVNRT. To be fair to you, it would be difficult for you to make out a P wave in this. The P wave is actually occurring somewhere here. Yeah, so that will make Shadab correct. It's an orthodromic AV reentrant tachycardia. The things that you should note, in general, an AVNRT is not this fast. You see here the rate is close to 300. A rate close to 300 is more likely to be an AVRT than an AVNRT. And having seen that, when you find you look for a P wave carefully. It's easier if the ECG is in your hand. But the rate, remember, a very fast heart rate is more in favor of AVRT. Okay? This is a different ECG. Anybody? Good, we know you are on the right track. Anybody else? Yeah, you should definitely think of atrial tachycardia in this, and I think your problem once again is not having the ECG in hand. If you see here, see these spiked complexes. That makes it very likely to be atrial flutter. So this atrial flutter with 2:1 AV block. Remember, whenever you diagnose atrial flutter, you have to say what is the AV conduction ratio. Diagnosis here. It is a monomorphic ventricular tachycardia. Very good, Shada. That's even better to say that it's VT from RV. Good. All of you have diagnosed as VT. That's very good, because here is a wide QRS complex tachycardia. The QRS complex has a left axis deviation, and it is an LBB morphology. The LBB morphology, see that it is dominantly positive in V6, and that dominant positivity in V6 makes it an LBB morphology. That means it's originating from the right ventricle. A right ventricular tachycardia, it could occur in a repaired tetralogy or some other condition where there has been an RV scar, or it could occur in an otherwise healthy person originating from the RV outflow tract as an RVOT tachycardia. But an RVOT tachycardia has an inferior axis. A left axis deviation is not a feature of an RVOT tachycardia. So if you would make out that it is a wide QRS complex tachycardia, it is a left axis deviation, and it is an LBB morphology, that is very suggestive of a RV origin tachycardia, and arrhythmogenic right ventricular dysplasia would also come in the differential diagnosis. Basically diagnosed as AVT. In this particular case, it is a status post ICR in a tetralogy. Thank you. Any questions that you want to ask? No, you don't diagnose left atrial enlargement in atrial fibrillation. In atrial fibrillation, if the left atrium is actually enlarged, you see a coarse fibrillation. That is, the fibrillary waves are rather prominent and coarse, as against a near normal sized atrium like an acute myocardial infarction going into atrial fibrillation, or a viral myocarditis going into atrial fibrillation. The flutter waves or the fibrillary waves are barely seen. But a mitral stenosis with atrial fibrillation, where the left atrium is enlarged, the fibrillary waves are very coarse. So you only and suspect that the atrium is enlarged, but you don't diagnose left atrial enlargement in the absence of a P wave. Yes, your question about RVH and RVBB, I showed you a slide that you look at the second R. If the second R is more than 15 millimeters, that suggests right ventricular hypertrophy in presence of RVBB. LVH in LVBB is tricky. In fact, in presence of LVBB, you cannot diagnose left ventricular hypertrophy. Yes, in V1 plus RV5 more than 45 in some criteria. In for LVBB, no. In fact, in children, more often we would require this 45 millimeter for diagnosing left ventricular hypertrophy itself, because the 35 is too small in small children. Many children tend to have voltage criteria of 35 normally. So SV1 plus RV5 more than 45 if you take in LBBB, it will not be correct. So it's better to hold the view that you can't diagnose LVH in presence of LBBB. So thank you, Shada. Good day to all of you. Thank you.